You're welcome to my channel. Today is going to be a little bit, will I say funny? Because it's like you are meeting someone who you have known in the past, but you are not aware that he or she had the name changed. So this is known in the past as ophthalmoplegic migraine, but the name has changed to recurrent painful ophthalmoplegic neuropathy. What is this all about? Without further ado, let's go. The first thing to note here is that the name is an old name and it has been changed to the new one known as recurrent painful ophthalmoplegic neuropathy in 2013. So we should be addressing it as such from now. This is a rare condition and more research is required to be able to get to the etiology properly. It is no longer a type of migraine. It was believed to be a migraine. Remember, ophthalmoplegic migraine was the old name. It can be confused with stroke, but it is a neuropathy. So, it has a new name, and that is recurring painful ophthalmoplegic neuropathy, not a migraine. It is a neuropathy. It has since changed in 2013. By way of definition, this qualifies as a neuropathy more than a migraine, and that was established in the year 2013. It is a form of neuropathy, meaning a nerve or some nerves are not working well. 6 cranial nerves are involved in both sensory and motor function of the eyes, and that will include cranial nerve 2, known as optic nerve, cranial nerve 3, known as oculomotor nerve, cranial nerve 4, known as trochlear nerve, cranial nerve 5 as trigeminal nerve, cranial nerve 6 as abducens, and of course cranial nerve 7 as facial nerve. The ones in red are the ones involved with muscular actions or motor function, while those in black are for the sensory function. By way of epidemiology, this phenomenon is rare. It's previously referred to as ophthalmoplegic migraine. Someone will say, you've said that and you are repeating it. Yes, we should know the new name because that will change how we approach it. It is common in people with migraine, yes, but it is a neuropathy. It can affect anybody, any race, living in any part of the world, but it's more common in children less than 10 years. Causes. In medicine, when we can't find cause or causes, we'll give it another name, known as idiopathic. So, we are not sure as per what is responsible. But we have a hypothesis that it's likely due to cranial nerve compression and occlusion of blood vessels or just decreased supply of blood to cranial nerves or the condition known as ischemia. It might also be as a result of demyelination. And then we can say that less is known at this time because the diagnosis has just been changed, a decade ago. Clinical features. Like the name implies, recurrent painful ophthalmoplegic neuropathy, it will be recurring, or we'll say it is episodic. There will be headache. And that is the reason for the past nomenclature, that is migraine but without aura. That has changed, right? Here there will be pain around the eye, known as periorbital pain. But remember, cluster headache will present in similar manner, but it is not cluster headache. The headache and neuropathy could occur at the same time, but may not occur together. The ocular and eyelid muscles will become weak. At the same time, painful. There will be drooping of eyelids. The pupil will be dilated, and diplopia, double vision or blurred vision. Still on clinical features, there will be decreased ability to look up or ability to look down without turning the head. In other words, the affected individual will have to turn the head while trying to look up or look down. Sideways gaze is also impaired and will be facing full features of oculomotor nerve damage. Still on clinical features, the duration of the attack varies. The neuropathy could be immediately as the headache occurs, or as far apart as 2 to 4 months. A repeat episode can be within 7 days or even 5 years after. How do we make diagnosis? Pretty simple. The history and the physical examination, and that's all. So it's done clinically. How do we treat? Well, we can reduce episodes with antihypertensive agents like beta blockers or calcium channel blockers. Then we can reduce, meaning elevate the pain and inflammation using non-steroidal anti-inflammatory drugs or some adjuvant like Neurontin or Lyrica. We can also use corticosteroids or intravenous immunoglobulin. In conclusion, this is a rare condition. More is required, meaning we still need to know more about this condition. But one thing is established today. There is no more confusion with migraine or stroke. It is not a stroke. It is not a migraine. It's a different diagnosis entirely, and it is called recurrent painful ophthalmoplegic neuropathy. You can go back to clinical features to pinpoint on the different characteristics of recurrent painful ophthalmoplegic neuropathy. How is it different from stroke? How is it different from migraine? With that, I come to the end of this short presentation. Formerly known ophthalmoplegic migraine is now known to be recurrent painful ophthalmoplegic neuropathy. It was formerly ascribed to migraine. Now it is known to be a form of neuropathy. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.